Hi, my name is Emily Blaslin. My presentation will be on Lyme disease, brucellosis, and leptospirosis. The first disease I'm going to discuss in my presentation is Lyme disease. Lyme disease is caused by the Borrelia burgdorferi bacterium. It is transmitted to humans through the bite of an infected deer tick. It is also the most common vector-borne disease in the U.S. Borrelia can cause neurologic, cardiovascular, arthritic, and dermatologic manifestations during dissemination and persistent stages of infection. Lyme disease was first recognized in 1972 in Old Lyme, Connecticut, when several juvenile arthritis cases were reported. 10 years later, a spear sheet found in ticks was thought to be the causative agent of Lyme disease, and the bacterium was later established as the causative agent after being recovered from patients and reservoir hosts. In this case, the reservoir hosts were mice. So Borrelia burgdorferi is an obligatory parasite. It's invasive and it's a persistent pathogen that causes diseases in humans and non-reservoir vertebrates, primarily through the induction of inflammation. The bacteria undergo changes in gene expression, leading to adaptation in the host. The microorganisms multiply and spread locally and induce inflammation responses that result in clinical signs and symptoms. So Borrelia virulence involves multiple mechanisms for dissemination and the colonization of multiple tissues and invasion of the host. The bacterium is a spirochete. It's never free living, and it's able to invade multiple tissues and susceptible vertebrates that cause infection and manifestation. Virulence factors allow for survival and adaptation to the host environment, which could be higher temperatures, an altered pH level, and different nutrient availability. The binding of complement regulators by different bacteria and proteins play a key role in its survival. Motility and chemotaxis are also important factors. Bonding to host tissue components allows for adherence to the vascular wall and extravasation. Acquisition of host plasmid aid in the invasion process. Borrelia have established mechanisms such as antigenic variation that allow for survival for extended periods of time. Patient symptoms early on, so within the first 3 to 30 days after the tick bite, include fever, chills, headache, fatigue, joint aches, and swollen lymph nodes. Erythema migrans, EM rashes, occur in about 70 to 80% of patients and expand over several days to 12 centimeters in diameter and greater. So the EM is not painful or itchy, and it resembles a bullseye. Later symptoms, so now days to months after the bite, include severe headache, neck stiffness, additional EM rashes throughout the body, heart palpitations, dizziness, shortness of breath, brain and spinal cord inflammation, nerve pain, and also numbness. Lyme disease is difficult to diagnose because it shares many common symptoms associated with bacterial infection, including headache, dizziness, and joint pain. The most distinct characteristic are those EM rashes, which look like bullseyes. However, like I said, they do not appear in every patient. So current diagnostic tests do not always detect early Lyme disease because antibodies take time to rise to detectable levels, and treatment is more effective when done in the early stages. Healthcare providers need to know whether a patient has an active infection or if they have had previous exposure to the disease-causing agent. Lyme antibody tests are the most common diagnostic tool, in which antibodies are looked for in the blood of those exposed to the bacteria, but it may take several weeks for a patient's immune system to create measurable levels of antibodies. This time gap can result in a false negative test. An FDA-approved lab test is administered to a patient who has demonstrated the signs and symptoms of Lyme disease. The CDC recommends a two-tier approach to testing. The first is an ELISA test, which is a conventional enzyme-linked immunoassay test, and then followed by a Western blot test. The ELISA test is a blood test that detects antibodies but does not test for B. burgdorferi, A positive result from this screening may suggest a current or past infection. So this test is designed to be sensitive, meaning that almost everyone who has Lyme disease will test positive. So if there is a positive or conclusive result, then a Western blot test is recommended to be used as a confirmation. So this test is designed to be specific, which means it will usually only be positive if a person is infected with the causative agent of Lyme disease. Currently, it's estimated that about 476,000 people in the U.S. are diagnosed and treated for Lyme disease each year. Each state's health department has the responsibility of reporting cases to the CDC. The state departments use a passive reporting system known as the Nationally Notifiable Disease Surveillance System, the NNDSS. This system monitors the geographic, seasonal, and demographical features of diseases. Since this is a passive reporting system, many cases of Lyme disease are misdiagnosed or go unreported just because there's a lack of resources. There's a high incidence level of Lyme disease throughout the Northeast and in Wisconsin and Minnesota in particular. It's key to look at this area because these are the areas that have a high prevalence of deer, which therefore mean they have a high prevalence of deer ticks, and therefore that is why Lyme disease is so high in this area. So for early detection, a course of oral antibiotics, such as doxycycline or amoxicillin, cures the majority of cases. However, for more complicated cases, usually successful treatment can be done with 3 to 4 weeks of antibiotic therapy. After treatment, however, a small number of patients may still report some symptoms, including persistent pain, joint aches, muscle aches, fatigue, and impaired cognitive function. There's no evidence of an active infection at this point, and the person may be diagnosed with PTLDS, which is post-treatment Lyme disease syndrome. There's been shown to be no benefit to additional antibiotic therapy in patients with Lyme disease. A few clinical trials have been carried out by the NIAID to test the efficacy of such prolonged treatment, and it's been found that there's no benefit at this point, and currently there's no vaccine for Lyme disease for humans in the United States. I wanted to briefly discuss why I chose to focus my presentation on Lyme disease. At the beginning of the discussion, I mentioned that Lyme disease not only affects humans, but can also affect animals, and it has demonstrated its ability to do this in my father, who is in the left with me there, and in my dog Tucker, who is in the picture on the right. In 1984, my father was in graduate school for engineering at Manhattan College. During this time, he lived there full-time, and so during that summer, he had gone to Westchester to fly fish. Little did he know that deer harboring ticks with Lyme disease were at an all-time high in the area. After he returned home from his fishing trip, he discovered he had a tick on him. A few days after that, an EM rash appeared. The telltale bullseye sign now was not as telltale back then, as Lyme disease had only recently been on the healthcare radar, so he had no idea what it was. His aunt, who was a nurse in the area, knew right away when he called and explained the EM rash and some of his symptoms. He was able to receive treatment through antibiotics, and to this day he shows no signs or symptoms. He is completely recovered. Tucker, my dog, is the other one in my family who has been infected. He is 7 years old right now, so 4 years ago I brought him to my grandparents' house in Boothbay Harbor, Maine. They do live right on the coast, but on their property they have woods on either side, and there is a high population of deer in the area. While we don't necessarily like it, our dogs like to wander in those woods. And unbeknownst to us, Tucker had gotten a tick when he was wandering in the woods one time, and after that trip, when we brought him home, he was acting very strangely. He wasn't eating, He was having diarrhea constantly. He was vomiting. He just was not acting like himself. We brought him to the vet, and he was diagnosed with Lyme disease. He was treated for Lyme disease, but the vet kept monitoring him for 6 months. And thankfully, after 6 months, he was declared Lyme-free. However, I also live in upstate New York, and Green Lakes is only 20 minutes away from our house. Green Lakes is one of the highest Lyme disease breeding grounds in upstate New York, and to this day, my family does not bring our dogs there just because we are so paranoid from that experience with Tucker getting Lyme disease. But thankfully, he has not gotten, and none of our other dogs have gotten Lyme disease since then. The next disease I will be talking about is brucellosis. Brucella are facultative intracellular gram-negative coccobacilli. The main brucella known to cause human diseases are B. abortus, B. militensis, B. suis, and B. canis. This is a bacterial zoonosis, as animals are the only source of infection. Most humans commonly acquire infection through the consumption of unpasteurized dairy product. It can also happen through ingestion of undercooked meat. However, this is quite rare because of the limited bacterial load located in muscles, but it can also be through direct contact with fluids or tissues of the infected animal, which can be a risk of exposure. So in this case, it would be a hunter dressing an animal. The bacteria can enter the host through skin wounds, mucous membranes, or by inhalation. Brucella lack well-known bacterial virulence factors such as cystolysins, capsules, exotoxins, secreted proteases, fimbriae, and phage-encoded toxins. The Brucella virulence relies on the ability to survive and replicate in the vacuolar phagocytic compartments of macrophages. Prolonged persistence of brucelli in macrophages leads to chronic infection, extensive replication of bacteria in placental trophoblasts, resulting in acute reproductive tract pathology and abortion in natural hosts. The brucelli life cycle involves 2 stages. The first is the chronic infection of phagocytic macrophages, leading to its survival and replication. The second stage is the acute infection of non-phagocytic epithelial cells, leading to reproductive tract pathology and abortion. After infection, the spleen and liver house a large number of the brucelli bacteria. Symptoms of patients include fever, sweats, headache, back pain, and physical weakness. In severe cases, the central nervous system as well as the lining of the heart may be affected. One form of the illness may cause long-lasting symptoms, including recurrent fevers, joint pain, and fatigue. Blood cultures are the diagnostic gold standard for this disease. However, isolation rates vary because of the stage of infection, previous antibiotic use, and the culture of the method used. Bacterial growth can be observed within 3 to 5 days in the culture, but should be held for at least 10 days before the culture is really considered. Serological testing is the most common method for diagnosis. The serum agglutination test, the SAT, is the standard method of serological diagnosis that detects IgM, IgG, and IgA. ELISA tests have a good sensitivity and specificity that detect IgM and IgG as well. There are some limitations to diagnosis. Most serological assays for brucellosis show variable levels of cross-activity with other gram-negative bacteria. Brucellosis antibodies can persist over a year despite successful antibiotic treatment. There's no validated serological assay available to detect antibodies produced against infections caused specifically by B. canis and the B. abortus RB15 strain. So if infection is suspected, a culture should be performed immediately. An estimated 500,000 new human cases of brucellosis are reported around the world every year. Brucellosis is often underreported because symptoms are nonspecific, physicians sometimes lack awareness, and lab capacity for diagnosis is limited. B. militensis is the most frequently reported cause of human illness in the world. B. abortus is the most widespread potential source of infection. Human infection occurs most among people who travel or live in areas where there is a disease epidemic in animals, usually occurring along the Mediterranean basin, South America, Central America, Eastern Europe, Asia, Africa, and the Middle East. B. suis, which can be found in fetal swine and reindeer, and B. canis, which is found in canines, are present in the animal populations, and travelers are at a higher risk of coming into contact with them. To treat this bacterial disease, a combination of doxycycline or oral tetracycline and rifampin for at least 6 weeks is recommended for those with uncomplicated infection. However, for complicated brucellosis, which could be endocarditis, meningitis, or osteomyelitis, an aminoglycoside in combination with tetracycline should be considered. Also, the duration of therapy for those with complicated brucellosis is extended to from 4 to 6 months. B. abortus RB15 is resistant to rifampin. Therefore, treatment for brucellosis due to this strain should be altered accordingly. Late diagnosis and even incorrect therapy may lead to a relapse. So the final disease I will be talking about is leptospirosis. Leptospirosis is a bacterial disease that affects humans and animals. It is caused by bacteria of the genus Leptospira. Without treatment, it can lead to kidney damage or meningitis, which is the inflammation of the membrane around the brain and spinal cord. The bacterial infection can also lead to liver failure, respiratory distress, and sometimes even death. Infection by pathogenic strains of Leptospira commonly occur through direct contact with an infected animal's urine or indirectly through contaminated water. Almost every mammal can serve as a reservoir for leptospiras, harboring the spirochetes in the renal tubules of the kidney, leading to urinary shedding. However, rats are the major carrier of this disease. Leptospiras adhere to the fibroblasts, renal epithelial cells, macrophages, and endothelial cells in the host. Severity depends on the strain and inoculum size of the bacteria, as well as the age, health, and immune status of the host. Some symptoms in patients that are associated with leptospirosis is high fever, headache, chills, muscle ache, vomiting, jaundice, red eyes, abdominal pain, diarrhea, and rash. Infected patients may also have no symptoms at all. The time between exposure to a contaminated source and showing symptoms is anywhere between 2 days and 4 weeks. Patient symptoms may occur in 2 stages. First, after the first phase, which is fever, chills, headache, muscle ache, vomiting, diarrhea, the patient may recover briefly. However, they can become ill again, leading to the second phase. So if the second phase occurs, it is more severe, and the person may experience liver and or kidney failure or even meningitis. The illness lasts a few days to several weeks, but without treatment, it could last for months. The pan-bio-ELISA test has been demonstrated to be more sensitive compared to the microscopic agglutination testing for detection of cases in the early stages of the disease. Leptospirosis can be diagnosed on the basis of the presence of IgM antibodies by the pan-bio-ELISA test in a single serum sample collected during the acute phase of illness. A convalescent sample taken after 2 weeks is required to confirm the results of the first test. From 2014 to 2018, the U.S. reported 100 to 200 new cases of leptospirosis annually to the National Notifiable Diseases Disease Surveillance System, the NNDSS. Incidence in the U.S., however, is relatively low compared to other areas in the world that have higher temperatures, so those that are at a higher tropical or subtropical climate. Leptospirosis is considered one of the most widespread zoonotic diseases in the world. However, it's often underreported and misdiagnosed, as with many diseases. There are approximately 1 million cases occurring worldwide every year and 59,000 associated deaths. Leptospirosis is treated with antibiotics. In this case, it is usually doxycycline or penicillin, and it should be administered as early as possible. Intravenous antibiotics may be required for those with more severe symptoms. And here's the first page of my references. And this is the second page of my references. Thank you for listening to my presentation, and I hope it was informative.